I'm going to talk a little bit about ileoanal pouch. This is Richard's talk, which I've only seen once before, so you bear with me if I get things wrong. So he starts off by telling everybody who he is. So he is a consultant in Worcester. He's done quite a lot of pouch training, started off in London and Oxford, and then he did a 2-year fellowship in Toronto. So he has quite a bit of pouch experience going into becoming a consultant. So it talks a little bit about the history of when stomas were first referred to, and I think they were referenced in the Bible early on. The first surgical stomas were formed in the early 18th century, but most people who had them made did not survive. And then the first successful story was in 1793 in a 3-day-old baby who had an imperforate anus, so no back passage through which to open your bowels. And that person survived to the age of 45. The first ileostomy was made in 1879. Patient died 9 days after surgery. The first successful ileostomy was a few years later, and the first loop ileostomy a few years thereafter. So the early stomas that were made were flush to the skin. You didn't have very good appliances. I have never seen those things that are on that picture. I don't know if anybody else has, but I don't recognise those things. But that's what it looks like. I have had a colleague recently who's travelled to Gambia to do some charitable work, and he took a load of stoma bags with him because they don't have them easily accessible there. So it's interesting that although this seems like foreign to us, it may be some people's reality. And if you don't have the right appliance, as you all know, you get a lot of problems with skin breakdown and leakage. So this is the chap who was accredited with the Brook ileostomy, which is how we make them nowadays. Incidentally, I didn't know this, but he's also the founder of the Ileostomy Association, so I didn't know that, but that's Rich is full of fun facts. So this is an ileostomy. It is a bit of bowel that's folded over back on itself, so it stays above the skin, it's not flush against the skin, and it allows the stoma bag to sit around it and make a better seal. It also keeps all the things that are draining out of the bowel away from the skin. There is still stoma avoidance, though I am quite happy to see that it's not as it was, say, 10, 15 years ago. There's a lot of social media out there that promotes having a stoma, and quite a lot of young patients come and sit in my clinic and are actually happy to have a stoma. It's often the older patients who are more stoma averse, which I find really interesting. And I think part of it is due to acceptance, but also some of the technological advances that mean that your quality of life isn't affected in the same way as it may have been previously. So that, I believe, is somebody having an operation from a very long time ago, but I don't know why that isn't there. But that is what we would aspire to be like now. That is not what my theatre looks like in Coventry, and I'm pretty certain that's not what like Worcester's looks like either, but that is the one all-integrated theatre setup. Asepsis is very important to make sure that whenever we do surgery, we have good outcomes. And it started off with simple things like hand washing and sterilisation of instruments, and has led to better surgical outcomes overall. Antibiotics mean that we can treat people when they develop infections now. So again, infective complications are less prevalent and less important. So, I think you must have heard, I'm sorry I missed most of the talks in the morning, but so I don't know what discussions have been had, but essentially, once you've had your colectomy, what are your options? And the options are, we either take the ileostomy and join it back to your rectum that's left behind from the first operation, or we remove the rectum completely and leave you with a bag, or we take the rectum away and do the ileoanal pouch. Generally in this country, an ileorectal anastomosis is not offered very often. There are certain groups of patients for which it's really good, but for the vast majority we would probably prefer to say have a pouch or leave you with your ileostomy. So an ileorectal anastomosis in this country is not done very often, but it is done fairly often in the Nordic countries. So it's mainly a Scandinavian practice. So these are the surgeons who devised the ileoanal pouch and first formed it. They started off as an ileoanal anastomosis, but we can take the way in which you make that pouch, and instead of plumbing it down to the bit of rectum that's left behind, you can make a cock pouch, and sometimes you can reverse it with an ileoanal S pouch. So lots of words there, but essentially you're taking a bit of small bowel and folding it in various different configurations to make a pouch, so it's not as narrow as a small bowel normally is, and it's mimicking a rectal reservoir. So your rectum usually is the bit of your bowel that contains all your feces and holds it and stores it. What we're doing with a small bowel is turning it in some configuration to create a wide reservoir that will hold your stool before you then can expel it. I don't know if anybody is familiar with cock pouches. Anybody in the room have a cock pouch? I know you do.
I want one.
Okay. He's the expert with the cock pouches. He's probably one of the only people in the UK still doing them. Sometimes they can take a J pouch and reuse it, but essentially the way in which a cock pouch is made, it's the S configuration. So you need to use a lot more bowel with a S shape than you do with a J shape, but that's what it looks like. It's basically a continent ileostomy. So there's a pouch that sits behind the surface, and then you have no spout, an ileostomy that's flush against your skin. It usually sits quite a bit lower than where a conventional ileostomy sits, and it's completely continent, so you don't have to wear a bag. You have to have a special catheter that goes in. It allows you to empty the pouch, and then you can put regular dressing or keep it open. She's the expert though. So as I was saying, S pouch, this is what they used to do. We don't do it as often. It's a way in which you basically fold the bowel as an S, and then you stitch the two limbs of the S together, and that then creates a pouch. There are technical reasons why you would do one versus the other. You tend to do an S pouch if the bowel length isn't long enough to reach down. If the bowel length is long enough to reach down, then you usually make a J. Who is it suitable for? So generally for ulcerative colitis, people who have FAP and HNPCC, so they are hereditary syndromes where you develop lots of polyps in your bowel, often a precursor to developing a cancer. So those patients will have a prophylactic colectomy. So prophylactically you will remove their bowel to stop them developing a cancer. You often do it when they are teenagers or young adults. So those patients are offered a pouch. And then what he means by selected other patients, I think, is patients who may have indeterminate colitis, and then there are a couple of patients groups where you might not conventionally consider it. So if you have ulcerative colitis and a liver condition called PSC, we might not offer you a pouch, but in selected patients you could consider it. So not suitable potentially for Crohn's. So I think most people, if you have a diagnosis of Crohn's to begin with, you will not be offered a pouch because we know that the failure rate is really high in Crohn's patients. But there are a cohort of patients where we think you have ulcerative colitis, and many years later we find out that actually it's Crohn's. In those patients, they may have had a pouch already. Indeterminate colitis is a risk, so we don't really understand that, but my sort of subjective theory behind that is that indeterminate colitis is Crohn's that we can't diagnose as Crohn's. So eventually it turns out and behaves more like Crohn's than it does like UC. Functional bowel problems, again, in selected groups you may consider it, but if you have a functional bowel problem, it means your bowel's not moving like it should do, and then you make a pouch, it alters the whole dynamics of how your bowel's got to work, and it tends to result in a poorer outcome. If you have cancer, then we know that when we do a pouch, and I'll talk through this a bit in the next subsequent slides, you leave a little cuff of the rectum behind so that you can join the pouch onto it. There is always a theoretical risk that you could develop a cancer in that little cuff, but if you've already had a cancer, you're at higher risk of developing a cancer. So we don't want to leave any cuff of any tissue behind that could subsequently develop into a cancer. So if you have a cancer, it's a relative contraindication. It's not an absolute thing, but it's relative. Anal incontinence, if you've got problems with holding on to your stools already and then we make a pouch, you've got to think that there's going to be a lot of more liquid content coming through, and if you can't hold on to the solid content, you're not going to be able to hold on to the liquid content. And again, relative contraindications, older age and obesity. So, do I need a pouch? So I don't think anybody needs a pouch. I think anybody should want a pouch. There are different ways to make it. So you can make a pouch all in one go, and I know surgeons who will do that without doing an ileostomy ever. I have a few sort of hesitations with doing that, because if a pouch fails, you end up with an ileostomy, and if you've never lived life with an ileostomy, I don't think you can really make a decision between a pouch and an ileostomy. So I feel that a 2-stage or a 3-stage is better, but there are some patients who are so stoma averse, and if we're able to, we can do a 1-stage procedure where we take the whole thing out and do the pouch in one go. It's relatively rare to find that you're in that situation. The only time you would do that really is if you've got medically refractory colitis. If you've got active colitis and you need your colon out, then you wouldn't do it all in one, because when you've got inflammation there, you then try and do a pouch, it doesn't work very well. So you want to do it when somebody is well enough for it all to heal. So a 3-stage is what most people will have. Occasionally people will have a 2-stage where they have the bowel removed and they have an ileostomy for a period of time. Then you go back and you remove the rectal stump, you make the pouch, and you give a loop ileostomy, which is temporary. You then test the pouch and make sure the pouch and everything is healed, and then you close the loop ileostomy. That's what most people's journey will look like. But some people will opt for not making an ileostomy when they have the pouch made. In that cohort of patient, if there is a problem with where that we've done that join between the pouch and the last bit of bowel, if you haven't got an ileostomy, then it makes it very tricky to deal with the infection. So the reason for making the ileostomy is to make sure there's no bowel content going through and allow that area to heal. And like I said, very few patients will be offered a 1-stage procedure. So this is a nice bit of bowel that he's removed. So that subtotal colectomy is often keyhole. It removes the bulk of the disease, but we leave you with a short rectal stump. It allows us to stop your medical treatment, because most of the time the rectal stump doesn't require biologics and other medication to control the disease, and you can often give local treatment like enemas and suppositories if the rectum becomes inflamed again. And like I say, I think Richard and I both agree that it allows you to live with a stoma and therefore then make an informed decision about whether you want that long term or whether you want to go for a pouch. So proctectomy involves removing the last bit of the rectal stump. That can be laparoscopic, open or robotic. So laparoscopic is conventional keyhole surgery. A lot of the time now we're doing robotic surgery. It's the same thing. There isn't a magic robot that whizzes around and does the operation. There is a surgeon sat there who uses the robot to do the operation. But it does allow us better field to view, and it's more precise. So actually the surgery turns out to be a lot more technically better, I think. Whether that then translates to patient outcome is the bit we don't know. So what difference does it make to your recovery is a bit we don't really have much evidence for. And then you make the pouch. So you take the last 30 to 40 centimetres. So say where your ileostomy is, we take 30 to 40 centimetres of the bowel from that ileostomy, and then we fold it back on itself. Now this is a J pouch, so it's folded literally like a J back on itself. That's what it looks like in real life. So it's got 2 limbs. There's a short limb, and then it comes round to the rest of the bowel. We then usually use a stapling device to put the 2 ends of bowel together, and then the bit at the end is the bit that goes on to. Hang on a minute. There is a pointer here. So this bit here is the bit that plumbs onto the back passage. So the J is like from there and back up. So that's the stapling instrument that we use to bring the 2 ends of bowel together. And then at the end is this blue thing here. So that blue thing is a round circular bit of stapler that then comes from, so we put that in to the pouch, and then it's got a little area, a little handle that comes out, and then from the bottom we put a gun up, and that fixes onto here, and then it staples around here. So that's what it looks like. For those of you who want to know that, some people don't want to know that. Yeah, well, that's it. I think sometimes ignorance is better. But that's what it looks like in reality. All of this is going to make my subsequent talk a lot easier. So this is an S pouch. This is rarely done. But I don't know if you can sort of appreciate that there is an S sort of going back on itself. This is technically a lot more difficult because you have to stitch it all. And if you don't stitch it right, you end up with areas which don't come together very well. So a lot of surgeons choose not to do this anymore. It used to be done quite a lot more before we had the fancy stapling devices. But because we've got the stapling devices and they're fairly reliable, we don't tend to do this anymore. This is not done at all. I think I've only ever seen one of these by somebody who retired many years ago. It's a W pouch. It makes a big pouch. So there was a whole vogue where we thought making big pouches would be really good because you would store a lot of bowel content before you then opened your bowels. But in reality, what happens is you can't open your bowels because the pouch is so big, it just doesn't move. So you get a lot of problems actually evacuating your bowels. So it's completely gone out of favour. And then this is an ileorectal anastomosis. I don't know if anybody has heard of this, or most people heard of pouches. Something that anybody is aware of? Yeah?
Yeah. There was some good data on this from the Danish group.
Yep. Yeah, so the Danes do it a lot. The Swedes do it a lot. They swear by it, but their practice doesn't have pouch in it. And they tend to do it for people who have rectal sparing. Now, as you know, ulcerative colitis starts from your back passage and goes all the way around. So there aren't many patients who have this rectal sparing. And it's also, if you do it, you need to continue to have topical treatment for the rectal stump. So you will be signing up to having suppositories or enemas after it's done. And so what this journey looks like for this is you have your colectomy, then we give you the topical treatment, and you try that for 3 or 4 months, and then we do a camera to see whether it has responded to the topical treatment. And if it looks like the inflammation in the back passage is gone, then we could consider it. But once it's done, you still need to continue with the topical treatment. The other bit of it is that sometimes when you've done a colectomy, your rectum shrinks because obviously it's not being used anymore. If your rectum has shrunk like that, and then you try and do a join with the small bowel and the back passage, it won't work because it won't stretch to accommodate anything, and so your function will be really bad. So it has to only be done in people who have a rectum that stretches when you do the camera. So that's the way to know whether you're suitable or not. So usually this involves taking down the ileostomy, so you putting the ileostomy back into the tummy, taking a little bit of the top of the rectal stump away, and then you join the small bowel to the rectum. Usually means you go to the toilet 3 to 4 to 5 times a day. You do get good control because you've still got your rectum there, so it's not the same as the pouch. Your rectum still behaves like its normal reservoir, so your functional outcome is usually pretty good. It doesn't have the same complication rate like an ileoanal pouch, and if it fails for whatever reason or it stops working, you can go back and make a pouch. So it doesn't stop you having a pouch in the future. So the way the Danes do it is they do this first, and the average sort of length of time people stay with this is between 10 and 15 years, and then they can either come back for a pouch or they can go to an ileostomy. So post-operative care, if we do it all planned, particularly at your colectomy, it's usually done keyhole, means that you're not in hospital for as long and you're less likely to have complications. If we do it as an emergency, you're more likely to be unwell. There's a higher chance of making an open operation. You often need nutritional support, like we heard, preoperative TPN, and sort of way to optimize your recovery afterwards. You often stay in hospital for a lot longer, and they're more likely to have complications. So I don't know what he means by tubes everywhere. But a subtotal colectomy in most hospitals now is done keyhole, even in an emergency setting. And it does mean that you end up with a smaller incision. It also means that when you go back to make a pouch or to remove the rectal stump, you can do that keyhole, and your recovery from that operation will also therefore be quicker. Progressive removal of tubes, I think he means the drainage tubes and things like that that are being put as part of your recovery. Physiotherapy, and usually people go home between 5 and 7 days. And we do give people Clexane for 28 days afterwards. We do know that if you have inflammatory bowel disease and we do an operation of this nature, you're at 2 to 3 times the high risk of developing a blood clot. So most hospitals will now give you Clexane injections to thin your blood for 28 days afterwards. Once you've had the ileoanal pouch formed, we then do a contrast enema. Some people will combine that with our physical camera test to make sure that the area where we've done the join is healed and is working, and then you can reverse the ileostomy, usually looking at 3 months, occasionally a bit earlier. But current waiting times are longer, as he says. So even though you might get the contrast enema within 6 to 8 weeks of surgery, by the time you come round and you're on the waiting list and you get a slot, can be longer. So that means living with that loop ileostomy for longer. IRA, which is the ileorectal anastomosis, is very similar to a colectomy. We would put a rectal catheter in. I don't know if when you have your colon or your colectomy, your bowel removed, the last bit of the rectal stump, sometimes we'll put a catheter in, a bit like the catheter goes in into your bladder, but wider, and that allows anything that builds up in that back passage stump to come through, so it doesn't put pressure on the area where we've stapled it. Because obviously if it puts pressure, it's like a closed balloon, it'll explode, it can open up. So we don't want that to happen, so prophylactically we put a drain in, and usually people do go home 5 to 7 days later as well. So what are the advantages of the ileorectal anastomosis? Good for sort of body image, no more stoma bags, and avoids pelvic surgery. Now it's that bit about the avoiding pelvic surgery, and it was really nice to hear the story about having the 2 children after an open ileoanal pouch, because a lot of young women will ask, should I have my surgery now or should I wait until I've had my children? And there is pretty good evidence out there that does say that if you do have any pelvic surgery as a woman, your fertility is reduced. But we don't know who for and why. So you can't tell somebody that it's going to happen to you or not. And that makes it quite difficult then. So this is a good option for those patients, because it means that you're not going down to the pelvis, so their fertility is not going to be affected in the same way. The disadvantages are that you do still have your rectum still there, so you can get the same colitis that you had before. There's always a risk of developing a cancer in that bit of bowel that's left behind, and you may then need another operation to remove that rectal stump. So it just increases the number of operations you may end up having in the long term. Ileoanal pouch, again, no stoma, passing stool through the back passage, which for some people is very important, and improved body image because there's no stoma there. But like I said, risk of fertility is still there. Functional outcome is variable, and there is a failure rate. So there are significant challenges with a pouch that you often won't have with an ileorectal anastomosis, and certainly won't be even in the vicinity for staying with an ileostomy. So I think that's something to bear in mind. And that's his talk.